good afternoon, and welcome to today's CME activity. There is no commercial support. The speaker and planners have disclosed no relevant financial relationships with any commercial interests. You will receive a SurveyMonkey link after today's activity, and if you're viewing online, we will list that link in the chat section of the Zoom link. It is my pleasure to introduce Dr. Aleksandros Mihilli. He is from Athens, Greece, and moved to Toronto, Canada when he was 10. He decided to become a physician and went to medical school in the Caribbean at St. George's University. He is the first one in his family to become a physician, and now he gets to help his sister as she has decided to become a physician as well. Dr. Mihilli is particularly interested in GLP-1 receptor antagonists because of how they have helped him. He is a third-year internal medicine resident and is interested in hospital medicine and, I believe, working at night. Join me in welcoming Dr. Mihilli.
All right. So thank you, everyone, for coming. I'm Alex Mihilli. I'm a third-year resident in internal medicine, and today we're going to talk about GLP-1 receptor agonists. I don't have any financial disclosures. So today, our learning objectives are going to be to understand how GLP-1 receptor agonists function, their use in diabetes and in weight loss. We're going to compare the available GLP-1 receptor agonists in terms of efficacy, some things about which is appropriate to use when, and then we're going to look at some future advancements in the field that are coming in the future. So to start off with, type 2 diabetes is a disease that occurs due to a progressive loss of beta cell insulin secretion, often in the presence of insulin resistance. As we all know, it can be diagnosed with an AOSC of greater than 6.5, fasting plasma glucose of greater than 126, or greater than 200 random plasma glucose, or after a 2-hour glucose tolerance test. So what is the cost of diabetes? So in total costs, they've risen from 2012, where they were $245 billion. The largest components of the medical expenditures towards diabetes are in hospital inpatient care and prescription medications to treat the complications of diabetes, and then to a lesser degree, the actual anti-diabetic agents, diabetic supplies, and physician office visits. And people with diabetes incur an average medical expenditure of $16,752 per year, about 9,600 of which is attributed to diabetes, which is approximately 2.3 times higher than what that expenditure would be in the absence of diabetes. The other associated medical condition that we're going to talk about is obesity. It's been designated as a chronic disease by the AMA back in 2013. And by 2035, it's projected to affect almost 1/4 of the entire world's population. As we know, an energy deficit is required for weight loss, so reduction in the caloric intake is the foundation of any strategy for weight loss. While lifestyle interventions and behavioral modifications are often the first-line treatment implemented, pharmacotherapy, in addition to this, often produces greater and more sustained weight loss. So this is from the American Journal of Managed Care. There has been no obesity guidelines to come out since 2016, and the previous ones were in 2013, and those are the only two that have ever come out. This article kind of summarized those findings from back then, and back then there were only 5 drugs approved for the treatment of obesity, which were orlistat, lorcaserin, naltrexone, bupropion, liraglutide, and phentermine topiramate. Lorcaserin, however, was recalled due to an increased cancer risk. And then in 2021, the semaglutide STEP trials were published, and semaglutide is now the other medication and one of the only 2 GLP-1 receptor agonists that are approved for weight loss itself. This meta-analysis here, published at the end of 2022 in The Lancet, summarized 143 studies with 50,000 patients and provided high to moderate evidence that phentermine topiramate and the combination and GLP-1 receptor agonists show the most efficacy in reducing weight in patients with obesity. Initially, liraglutide or phentermine and topiramate was the most efficacious. As you can see up there, see here how this works. This should be able to highlight. Should be able to highlight, they told me, so I'm trying to, but it's okay. It's up here. Phentermine and topiramate has about an 8% body weight change from baseline, whereas liraglutide, which was the second most efficacious, was only about 4.7%. But since semaglutide has come out, which we know as Wegovy, after the STEP trials, its now efficacy is about 11.4%. So it's much better than the others. Something of note is orlistat is used worldwide for weight loss, but after this analysis, it's questionable whether it's any better than just lifestyle modifications alone for weight loss. And metformin, which some people purport to be a weight loss, it can contribute to weight loss, is actually noted to be weight neutral. SGLT2s do cause some change in weight, but not very significant. This is the ADA's guidelines in use of glucose-lowering medications for the management of type 2 diabetes. It's a pretty busy chart, as diabetes is very complicated, but to summarize it, I mean, after initial treatment with metformin, if our target is glucose lowering, then our go-tos would be GLP-1 receptor agonists like dulaglutide or semaglutide, which have very high efficacy, or insulin, or some combination thereof. Those two are the most efficacious. The others are less efficacious for glucose lowering. In terms of if in the far end, you see that semaglutide and tirzepatide are the most efficacious for weight loss. And then dulaglutide and liraglutide also have a moderate efficacy as well, but not as high. In terms of patients with high ASCVD or who are at higher risk for cardiac events, GLP-1 receptor agonists and SGLT2s are recommended. You can start with either. If your A1C remains above the target, you can add the other one. SGLT2s are always, GDMT for heart failure. And then in CKD, both GLP-1 receptor agonists and SGLT2s have shown improvement in, lack of progression. However, there are some GLP-1 receptor agonists that have shown CKD benefit, and I'll talk about those in a little bit. So of the GLP-1 receptor agonists, they all have very high efficacy for weight loss, and the ones that have major adverse cardiac event benefit is dulaglutide, liraglutide, and semaglutide. And those are all neutral in heart failure as far as we know so far. There's also benefit for renal endpoints in these medications as well. The other medications that are being studied right now are GLP-1 receptor agonists in combination with a GIP, and that would be something like tirzepatide. It has extremely high weight loss potential and is actually under investigation for reducing adverse cardiac events and its effect on heart failure and in CKD, and those trials are currently in progress. So in patients with a high ASCVD, these three, liraglutide, semaglutide, and dulaglutide, would be the GLP receptors chosen, or an SGLT2. In terms of efficacy for weight loss, this is the order. So tirzepatide is the most effective, followed by semaglutide, while the others kind of decrease in efficacy. And metformin and DDP4 inhibitors are weight neutral. In terms of pros and cons, they're very high efficacy. They have a low hypoglycemia risk, whether used with metformin or in monotherapy. And they have the cardiovascular side effects for the three that I mentioned before. And the CKD benefits are for liraglutide and semaglutide. And they also, of course, have the benefit of weight loss. Their cons are the costs, which I'll talk about a bit more later. Sometimes renal adjustment is necessary. However, dulaglutide has been studied in patients with GFRs as low as 15, and has found to be fairly safe, so it can be used with lower GFRs. They are injectable. Patients sometimes have some resistance to injectable medications. The GI intolerance is the most common side effect, and there are some rare concerns with thyroid cell tumors and acute pancreatitis. Okay. GLP-1 is a gut-derived hormone. It stimulates insulin from pancreatic islet cells in response to oral glucose. and leads to a glucose-lowering effect. It's broken down by DDP4, and the receptor agonists that we're talking about are resistant to that degradation and therefore have a longer half-life. It slows gastric emptying, can be an appetite suppressant, and improves satiety, and decreases inappropriate secretion of glucagon, amongst other effects. So there have been 7 cardiovascular outcome trials using all the GLP-1 agonists, and semaglutide has shown a statistically significant reduction in death from cardiovascular events, along with the highest A1C reduction. And a post hoc analysis of the trials for semaglutide and oral semaglutide both have shown reduced relative risk and absolute risk reduction for adverse cardiac events versus their comparators, which were the other GLP agonists. The primary renal effect has been through reducing new onset severe albuminuria. And like I had mentioned, dulaglutide was given in patients with very low GFRs and was safe to do so. So it's one of the ones that is usually chosen for patients with lower GFR. But semaglutide did show the largest albuminuria reduction. Like I said earlier, the weekly semaglutide, 2.4 milligrams, is the only medication approved for chronic weight management, as is high-dose liraglutide. But this is the liraglutide is a daily injection. Semaglutide did show a greater than mean weight loss ratio and a greater percentage of patients who lost at least 5% of their body weight when compared to the outcomes of liraglutide versus placebo trial. And the one important thing to note is what's considered a meaningful weight loss is a weight loss of greater than 5% of body weight. That will come up later. So now discussing the GLP-1 agonists themselves. So the first one that was released, I won't be talking much about. It's exenatide. There are some that are way more preferred. It's called Bietta. I think the Bydureon was actually pulled off the market in some places. It's only 53% homologous to GLP-1, and its short-acting formulation has been one of the least efficacious for both weight loss and A1C changes. Lixisenatide, similar, was approved in 2016. It's also a daily subcutaneous injection. There's been 2 trials. It's met non-inferiority for A1C reduction versus exenatide. And in the other trial, it showed that it was better than liraglutide. Liraglutide was better than this at achieving A1C reduction. This one also not very frequently seen. And these are the 2 trials, that show non-inferiority for A1C reduction, but liraglutide being significantly better. And in this one, you can see that there's no significant weight loss difference between all of these, including liraglutide at this point. Liraglutide is known as Victoza or Saxenda. It was much more effective at reducing A1C. Both did lead to weight loss that was not statistically different from the other. But it was far better at reducing A1C to below 7 when compared to the weekly exenatide, and it led to better weight loss than weekly exenatide as well. So this is one of the only few medications that are approved for weight loss as Saxenda. This one, and like the rest that we'll talk about, are much closer homologs to the native GLP-1, and this one is at 97%. So you can see here that it shows statistically significant improvement in A1C compared to the others, the comparators, which are the earlier GLP agonists. And here, there's not much of a difference here in terms of the weight loss. However, in the green one here, this is versus dulaglutide that I'll talk about next, it is more significant weight loss. So dulaglutide is Trulicity. It was shown to be superior versus exenatide and non-inferior to liraglutide at lowering A1C. It's very frequently used now, especially because it's a weekly dosing versus liraglutide, which might have better weight loss effect, but that is daily dosing. It has also been shown to have good cardiovascular benefit. And it's said to have high weight loss efficacy and very high glucose lowering efficacy. And it's also been used in patients with eGFRs as low as 15, and thus can be used in renal patients. You can see here that it's non-inferior to liraglutide at A1C lowering, but it's much better than exenatide at both of the dulaglutide dosing. However, it's actually here, it's shown to be inferior in weight loss. It's shown to have better weight loss than placebo. However, it's out of all the GLP agonists, it seems to have the worst weight loss capability. Now, semaglutide, the one that we've all heard about in the news and elsewhere, Ozempic or Wegovy, and available now as oral Rybelsus. So initially, the sustained trials were for what ended up being called Ozempic, which is the semaglutide subcutaneous injection. It was superior in regards to its A1C reduction, the proportion of patients that reached less than 7% A1C, and it had significantly better weight loss. The Sustained 7 trial compared it to dulaglutide, and it showed improved A1C and much larger proportion of patients reaching A1C less than 7%. And the weight loss was also fairly significant with like 6.5 kilogram weight loss on average versus 3 with dulaglutide. In the Sustained trial versus liraglutide, it showed us the same improvements in A1C and proportion of patients reaching the target, and there was a higher amount of patients reaching the 5% body weight loss total than there was with the liraglutide. So you can see that here. All of the red bars are their semaglutide and the subcutaneous injection. And as you can see, there's significant difference between them and all their comparators. The other, and the same thing here, this is for the weight loss. So the pioneer trials were for oral Rybelsus, semaglutide. A lot of them were done in Japanese-only patients. They are also, they did show significant difference in A1C reduction compared to other GLP agonists. They can be used, they're not as efficacious as semaglutide subcutaneous, but however, they can be used as an option when patients are hesitant to take the injection, which I've encountered fairly frequently in clinic. And also the magnitude of the weight loss is less. So as you can see here, they're non-inferior to liraglutide, but they are superior to the lower doses of liraglutide and to dulaglutide in lowering A1C, despite being oral. And the weight loss potential is also greater. So the STEP trials are the trials that confirm the efficacy of the 2.4 milligram dosing of semaglutide that is called Wegovy. And this is what was approved for obesity. They increased that dose from 2 to 2.4, and that there was a significant dose-related weight reduction. And it's been pretty difficult to get in the last few months to a year, especially because of supply issues, especially in the lower doses. So it's very difficult to get this to patients. In the first STEP trial, lifestyle modifications were included. This is one of the first trials where they included both lifestyle modifications and the addition of a GLP-1 receptor agonist. And 86.5% of participants were found to achieve the targeted weight loss that I mentioned earlier as being meaningful of greater than 5%. The final one that we're going to talk about today is tirzepatide or Mounjaro. This is the GLP-1 receptor agonist and GIP combination. It first came out sometime last year, and the SURPASS clinical trials was initially versus placebo. It showed very significant reductions in A1C, fasting plasma glucose, weight loss, improvement in triglycerides, total cholesterol, etc. And then it was compared to semaglutide as well, which was previously the best of the GLP agonists. And I'll talk about those results in a minute. It was approved for obesity in late 2022, and or for diabetes in 2022, and it was actually approved for obesity under a different name about 2 days ago. So this is the trial comparing it to semaglutide, While there's significant decrease in A1C in both studies, every dose of tirzepatide has significantly better reduction in A1C and fasting plasma glucose than semaglutide, and as well as changes in body weight are much better with tirzepatide than they are with semaglutide. And this was the reasoning for starting the trials for tirzepatide to become approved for obesity. So these are the SURMOUNT trials that led to it being approved for obesity. And you can see here the difference versus placebo is significant. There's only a 3% weight reduction versus 15, 19.5, and 20% at higher doses. There's also been trials in obese diabetic patients, which has shown similar results. In this trial here, it showed basically patients who had took tirzepatide high dose, and these are patients who had achieved a 5% body weight reduction through lifestyle modifications alone, and these were separated to either placebo or tirzepatide 15 or 10 milligrams, and the ones with the 15 milligram led to an 18.4% additional on average weight reduction in addition to the 5% that they had initially lost, versus the placebo, which gained about 2.5% of the weight back. Upon review of this, there may be an additive benefit from lifestyle modifications. However, it's unclear as the demographics of the patient may have been different, so there's not enough data to make any specific statement about whether adding both is truly better or not. And this is the press release from 2 days ago or Wednesday, where Zepbound, which is tirzepatide or Mounjaro's new name it's marketed under for weight loss. This was just approved on Wednesday. Now, in terms of accessibility of these medications, for a lot of patients, we have seen, especially lately, because of their popularity in the media with a lot of famous people who can afford these medications, there's very inconsistent access to them. If they don't have insurance, they can be prohibitively expensive. And despite showing notable efficacy for weight loss, only 2 are approved. So in terms of cost, this is the one that I mentioned as being one of the least efficacious, and this is still $850. Liraglutide, the daily injection, is over $1,000. Dulaglutide, still $800. Semaglutide in all of its forms are in the high 900s. So this is Mounjaro, which is also $1,000, but luckily for who knows how much longer, but for now there's a coupon for $25 for patients that have diabetes. And I'll talk a little bit more about it later, but the same coupon will be available for the new formulation for patients that don't have insurance that covers it as well. And that's expected to be made available before the end of 2023. They said sometime after Thanksgiving. So side effects, one of the things that most patients are concerned about with most medications, but especially these, the most common are nausea, vomiting, diarrhea, occasionally constipation. The nausea can wane with duration of therapy, and it can be reduced with dose titration as well. What I have usually done is I keep patients at the same dose if they're having too much nausea, and instead of giving it weekly, we'll do it every 10 days or some form of dosing that works for them to minimize their symptoms. There have been reports of pancreatitis. However, upon reviewing the data, it seems that there's various cohort studies that show that there is a link, while others show that there is no link, and there's meta-analyses that show that there was no increased risk of pancreatitis. However, because of this, inconsistency, most people will treat pancreatitis as an absolute contraindication to GLP-1 agonists, and they won't prescribe it once the patient has an episode of pancreatitis. Other side adverse effects, hypersensitivity reactions, injection reactions. It's contraindicated in type 1 diabetics. Like I said, people with history of pancreatitis. It's to be used with caution in those with gastroparesis. Renal impairment, I mentioned earlier. Exenatide shouldn't be used below a 30 GFR. Liraglutide and dulaglutide can be used cautiously with patients as low as GFR 15. And of note, the gastric emptying delay that occurs with most GLP-1 agonists, oftentimes after several months of treatment does start to wane. So it's not as significant as it is at the start. So the fact that weight loss still occurs despite this initial period does show that it's not just the delayed gastric emptying that causes the weight loss. And the other almost absolute contraindication is a history, whether personal or family history, of medullary thyroid cancer or MEN2A and 2B syndromes, and most experts won't prescribe this to these patients. In terms of future directions, there's, as you can imagine from the cost of the medications and how popular they are, it's a pretty lucrative field. I think what would be useful is a comparison of GLP-1 receptor agonists along with versus things like the phentermine topiramate, like I discussed earlier, that's been shown to have pretty significant weight loss. See how they compare to each other and have some updated guidelines in terms of obesity management, since there haven't been any real ones since 2016. In terms of studies that are in progress, so pemvidutide is from Altimmune. It's currently a drug in phase 2 trial. It's actually a GLP-1 receptor agonist along with a glucagon analog instead of a GIP like tirzepatide was, and it's glucose neutral, so it's only being studied for obesity and NASH. Mazdutide is from Innovent Biologics, and it's actually currently in phase 2. They just released the phase 2 results at the end of October, and it's a study from China currently going on. It also targets the glucagon receptor and GLP-1 receptor, and basically after 24 weeks there was a 15.4% reduction in body weight, and when extended to 48 weeks, 51% of patients in this trial achieved 15% or more weight loss, and 34.9 achieved greater than 20%. Danuglipron is an oral GLP-1 receptor agonist down the pipeline from Pfizer at some point. So this is the other big, coming from Eli Lilly. It's from the company that released tirzepatide rather. This one is a GLP-1, glucagon, and GIP receptor agonist. There was a 48-week trial currently that was published back in August, and there is a dose-dependent increase in weight loss that's shown to be significantly more than any other medication that's been seen. As you can see up there at the top, I dropped the mouse. At the top, there is a 24.2% weight loss. And in the second graph, you can see that 5% was achieved by all three of the higher doses. 5% weight loss was achieved by all three of the higher doses of the medication. So promising future for the field. And for weight loss. So these are questions I was told to put up here. GLP-1 approved for weight loss was Wegovy. So the one that has a savings card at the moment is Mounjaro, and this is the one I wanted to talk a little bit more about. So it requires patients with type 2 diabetes who are not on a federal or state government funded prescription program. They have to have type 2 diabetes, and they need to be USA or Puerto Rico resident. If they're able to get it, this can be a great tool for a weight reduction med. Not $1,000. You can get it for up to a year. If they don't have insurance, they can get it for up to 2 years for this price of $25. And the new medication that was just approved for weight loss will also have this coupon for an unknown length of time until insurances start approving it. And which of the following have renal benefit? And it was liraglutide. And that's it. I want to thank Dr. Patel and Dr. Fung who helped me out. And this is the link.
Thank you, Dr. Mihilli. If you're viewing online and have a question, please enter it in the Q&A chat and we'll ask for you. Are there any comments or questions in the room?
Hi, Alex. It was a very good presentation. I had a question on your adverse effects slide. Now you said that GLP-1 is contraindicated in type 1. Can you clarify it more?
So it's not an absolute contraindication, but there's been no real studies at the time at this time that they're not really being used. So
Okay.
there's no, it's not
Because
really,
I know that there have been like some studies going on
Yeah.
where they are studying, especially in like early type 1 diabetics, because
yeah.
they have their pancreatic function still preserved.
It's so yes, it's not an like necessarily a contraindication so much as there hasn't been a lot of studies, so the guidelines haven't really been, I think, updated quite yet. But I think in the future it's very possible that it would be used.
Great presentation, Dr. Mihilli. The question I had is about the same slide. So gastroparesis, coming back to it,
Mhm.
that is known with these medications being great for weight loss and diabetes control.
Mhm.
In the trials that you went through while these drugs were being studied, as we all know that a lot of diabetics would have baseline gastroparesis, especially if uncontrolled for long periods of time. In any of these trials, was gastroparesis considered to be a limiting factor, or when they were considering patients to be included in the trial, or no?
So I think I don't think it was considered a limiting factor. I think it's been used with caution. So a lot of the times the side effects of the medication would, exacerbate their gastroparesis to the point where some did have to drop out of the trial. So I don't think they were really excluded from what I've seen, but it's a consideration. They're used with caution, meaning like in lower doses. And with much more careful monitoring, because I mean, if they already have delayed gastric emptying, you're right, the delayed gastric emptying effect from the medication could kind of worsen their symptomatology, and who knows what other effects. Yeah.
Hi, great presentation.
Thank you.
In your research, did you happen to come across any other side effects than the most common ones, nausea, vomiting, and diarrhea? Anything related to dermatology, skin issues, hair loss, or anything like that with any of the drugs?
I don't believe I saw anything about hair loss. I think the only skin-related stuff is for injection site reactions. Like, so wherever you put it, wherever you do the injection, there could be injection site reactions, as with all injectable medications. And hypersensitivity reactions could happen with any medication as well. There's nothing specific that I saw.
As a physician for many years, I retired nearly 3 years ago. I like holistic natural medicine along with regular medicine. Sorry. A physician in my residency got me started on this. And it happens to be Gymnema. It's one of the things you can take like 1 hour before you eat or 45 minutes before you eat, which is fantastic. It curtails your appetite and it cuts down the flavor of sugars in your system, so you won't eat as much. So that's one of the things. The other one for sugars, you got xylitol, you got also stevia, you got other sugars that you can use that won't have the same effect as, because everything right now is completely laden with two types of sugar, glucose and fructose, and you got fructose everywhere. Even Coca-Cola now uses corn syrup, and what they fatten pigs with is corn. So here you go, you're taking more and more fructose with everything. Everything you got to read them, and you're going to see the amount of fructose it has more than anything else at this point in time. And the other thing is we're heading the way that we're you're working 8 hours a day here in the hospital, whatever not. You got very little time to go out and work out in the gym or whatever not. So sedentary life is also helping us to get more obese, and diabetic.
Yeah,
That's
those are good points. I haven't heard of some of the stuff that you said, but I'll look into those. Yeah.
Oh, I forgot. The other one was milk thistle. Milk thistle regenerates your liver. And the majority of obese people or diabetic people also have steatotic liver changes with micro steatosis of the liver. So that's another one.
Okay. This is any insight into why these therapeutics are underused by minorities and women?
I mean, I'm not sure as to why they're underused by minorities and women. The one thing that I can think of is they might be either less prescribed, less available, As I mentioned, people with a lot of resources are able to pay for these medications and get them outside the regular means that we have to go through. So people who have less access to, vast amounts of money to pay the prices that I put up there
Right.
would definitely be able to, kind of make the supply more scarce for for groups that are underprivileged. So that would definitely be a reason.
Thank you, Dr. Mihilli. Great presentation.
Thank you.